to see the screen?
Yes, we can see it.
Okay, perfect. So thank you for the kind intro, Maddie. Appreciate that. And thank you everyone for being here. We really appreciate it. Human and I, we both wanted to, we'll do 2 lectures. This one is going to be focused on insomnia, kind of talking about the general approach to it. And then also we'll dedicate some slides specifically for how it presents in cancer patients as well. So next slide. So insomnia, as we all, I'm sure most of us have experienced it at some point in our life, can be difficulty falling asleep, or you have difficulty staying asleep. And sometimes it's also that you are having early awakenings and then having difficulty falling back asleep. And usually also causes a lot of distress or impairment because you're not getting a good rest, the choppy sleep throughout the night. And for a full diagnosis, usually needs to present like 3 nights per week for at least 3 months. And insomnia usually doesn't really present on its own, and most often is associated with other medical problems as well. And that can be, psychiatric, like anxiety, depression, or other medical illnesses. Sometimes it can also be because of medications that we're taking or any supplements, other things. Or also other sleep disorders can be associated with it as well. Common one can be like sleep apnea. And this slide, it kind of, just to talk generally the age group and when we start to see some, insomnia. Usually when you're younger, childhood or young adults, usually kids, sleep well. And we really start to see it more as we get into the Middle Ages. There's going to be change in sleep stages. There's also people will have increased awakenings, any light noise can startle and wake you up. And you may notice that you're going to bed earlier and you're waking up earlier as well. And if you are trying to, stay up later, then it's going to cost you now. Now it's going to be, you're not going to feel as rested if you're not getting your sleep that you need. And later in adulthood, we can have more changes. And then we see more and more insomnia the older we get. Next slide. And what happens if we're not getting enough sleep? It can really decrease your energy levels. It can really affect your mood, right? So not only that, having underlying issues of anxiety or depression can cause insomnia, but because you have insomnia now, it may further affect your mood. You can also have difficulty focusing or remembering things. And then, also if you're not sleeping well, that can increase risk of accidents, like, if you're falling asleep while driving, leading to more injuries. And it's difficult to also manage stress because your brain is not getting the rest it needs. You may also not react as fast as you would. And decision making can also be affected because of poor sleep. And all in all, it can also affect your overall health. So, you're suffering mentally, but you can also suffer physically because of not getting enough sleep. And this slide kind of depicts what's kind of happening in these three ways that we can look at insomnia. There can be the picture to the left. There can be predisposition factors, meaning there's already something underlying going on, right? Some medical illnesses that a person has, and now it's difficult for them to sleep because of it. There can also be things going on in your life, with your health or finances or a big exam coming up that you're constantly tossing and turning and thinking about those things. And then there can also be habits that we have developed, right? We all have phones or, TV or something that we're looking at prior to bedtime. And then the more we're looking at it, the more difficult it's going to be for us to fall asleep or get a, good restful sleep. And generally, the approach that we want to do is kind of like step back and overall approach to see what's going on, because often insomnia is just not a single thing, right? So we want to look for, is there something else ongoing? Do you have any other medical illnesses that could be contributing to this? So trying to find that and making sure that we, first try to treat that, and that itself will help with the sleep. But then in the meantime, also working on sleep hygiene, and that we'll talk about in the next few slides. And there's also relaxation techniques that you can do yourself, at home, which can also help. There's also behavioral therapy that can be done. And then the last resort would be medications. So I know this is a kind of a busy slide, but we kind of wanted to put together different things associated with insomnia. So on the left side, we have, like depression, anxiety, other psychiatric illnesses. And then we have, for medical, we talked about sleep apnea. That can be a big contributor as well. You can have, if you have any lung diseases like COPD, that can affect your sleep as well. And I think another common one, things like heartburn, which can also be very common. So something like that can also affect your sleep because it can cause you to wake up at night. Or if you're having trouble, you're getting up at night to go urinate a lot, right? So then that is also then disrupting your night. So we would want to make sure that we figure out the underlying cause of why that's happening and treating that. That way you don't get up as often to pee, and that way you're having better sleep. And for, women, menopause can be a big thing as well. So making sure that we're helping you control your symptoms for menopause. For under neurology in the brain, I think the big things to think about is like jet lag. I'm sure many people have experienced that. Very common. So, and if you've suffered through like a stroke, or if you have headaches, a lot of those, and then peripheral neuropathy, which can often happen with, chemo treatments, or if you have diabetes, and those symptoms are not managed, you may feel pain and then, be awake because of that. So we want to make sure your symptoms are well controlled, so you're not waking up because of them. And neurology, the other part would be the medications, other things that you're taking. Alcohol time can also disrupt sleep. And then other medications or steroids that, usually people can be on, and that can cause awakening. It kind of wakes you up. So probably want to take them earlier in the day, because then it would be difficult to fall asleep. So usually your physician would have to kind of review all of these things, keeping these things in mind, and then, making a plan for how to treat the insomnia. Okay. Any questions at this point? Okay. So we want to talk about, I know we mentioned sleep hygiene initially. So mainly we want to make sure that we're regulating our sleep schedule. And I think of it like when we are trying to train babies to sleep, right? We usually have them on a schedule. That way the brain gets to that pattern and they're able to fall asleep more easily. So that's something we would have to start over again and make sure we incorporate that in our schedule. And the key thing is going to be making sure that you go to bed when you're actually sleepy. If you're in bed and you're tossing and turning, it's been 20 minutes or more, then getting out of bed, stepping outside, going to the living room or something and reading like a really boring book. And if you're starting to feel sleepy, that's when you would go back into bed. And making sure also that you're not too hungry, because then if you're hungry, then you may wake up, or if you're too full, then it's going to be uncomfortable, maybe some heartburn. So we want to make sure that we avoid that. And exercising regularly and early in the day, mainly because when we exercise, that does get us kind of pumped up, all the adrenaline, so we want to avoid that closer to bedtime. So probably earlier in the day it would be better, and avoiding alcohol or caffeine closer to bedtime, and also any screen time. Every time we're looking at a phone or a TV, it further delays us falling asleep. So I always recommend patients to not have any TV or screens in the room, making sure the room is quiet and dark, and your bed should kind of only be used for sleep, sex, and or if you're sick. But otherwise, don't spend too much time on your phone in the bed, because then that becomes a habit. So we don't want to continue with that. And the last thing is napping. It's kind of depends on, I think, person by person, but I think that if you are napping too much during the day, that's going to be difficult for you to fall asleep at night. If you want to do naps, I would say try to keep them short, maybe 20 minutes, 30 minutes max. I wouldn't recommend sleeping for a couple hours during the day, because then again, that's going to mess up your schedule. So key things are making sure you start forming a schedule, making sure that you go to bed when you're actually falling asleep. And if you are not sleepy, you step outside of your room and do things that are going to be boring, like reading a book. Again, don't watch TV, because that's going to, again, not going to help you make sleepy. So read a boring book and then go back in when you are sleepy. And then, we want to make sure that we continue this cycle. Okay, and I'll let Dr. Behrouzadeh take on from this slide.
Thank you. Yeah, so hope everyone hear me okay. So basically, this slide also kind of the repeating in a different way of what Dr. Gill perfectly explained about some sleep hygiene. And the important is, again, the element of a good sleep that comes back down to the sleep hygiene. So if we have any other factors that we talked about as far as the physical, mental, or precipitating factor, anxieties, all that being said, we doing the root cause analysis for it, but then at the end of the day, the sleep hygiene is the most element that we need to have it established to help with the sleep. And again, so we talking about from the top, the sleep routine, as Dr. Gill mentioned it too, that will help. And sometimes maybe some of us don't sleep good at night, but we have a better sleep at the daytime. Some people used to work night shift. I worked night shift myself for many years. So sometimes it's different adjustment and perform better at night and then sleep in the morning. So as long as it's collaborating and correlating with your work schedule, so it should be okay. It's just a different timing. But if you want to go back again to a night sleep with the daytime working, then we have to slowly, half an hour to 1 hour, make that changes for the adjustment by having that sleep routine. Same thing as Dr. Gill mentioned, having nicotine, caffeine. All this slide provided basically based on the study could be different from one individual to another one. However, this is the main thing that most people that work for them the best. So having caffeine and nicotine after 3 p.m. May cause difficulty of sleeping again. The sleep environment, exactly the same as Dr. Gill mentioned. In regard to the napping, so what most studies showed, there are some people, they cannot nap If they nap, they need a good 2-3 hours sleep in the daytime. So they would prefer to not nap until at nighttime, so they have a better night's sleep. And some people are nappers. So for example, they can do a 5 minute nap, a 10 minutes nap, and they completely recharge them. I'm one of those people. I if have a 15 minutes to 20 minutes nap, that will make me a complete good quality of work daytime without affecting my night sleep. But what they came up at the end was sleeping more than, they said 30 minutes, but the best is like a full 20 minutes sleep in the nap in the daytime. More than 30 minutes may cause interference with the timing of the sleep at night. So if you are napping, probably not a bad idea to keep it around like a 20 minutes, 25 minutes. Same thing goes with health and illnesses, stress, everything we control for a hygiene. As Dr. Gilligan mentioned about the meal, if you're too hungry or too full, it may cause difficulty using a device's screen and the physical activity. So high intensity physical activity usually helps with a good sleep if it's done in the afternoon, but not really later than the 7 p.m. So by circadian, we have the best per study, the best body activity, physical activity would be around like a 5 p.m. to 6 or 7 p.m. But after 7 p.m. would interfere with the sleep. Again, that could be different with the individual who can go sleep at 7 p.m. or 8 p.m., but they're doing really well in the gym in the morning. Moving forward to the next slide. So some of the technique we could use, meditation, obviously. And again, these are based on the studies and may or may not work for some people or have different effect. There are applications on the phones. There are guided therapies or meditation on the phone. There are the one with the music. There are actually with the screening time with some sort of motion with the color that helps you fall asleep easier and quicker, or some sort of a nature music, or some guided meditation that help you start from one point to the end for about a good 10-20 minutes meditation that you can use. Either you can purchase it online from different apps or their podcast that you can use for meditation. There is a technique called progressive muscle relaxation. So this is a very well-known technique. It would take some time for some people to start getting used to it. What happens basically as you lay down or even sitting in the chair at work, you start from head to toe. You focus on particular type of area of your body. For example, on your head, you think about your cheekbone. You try to have your muscles spasm, like constricted, or either shoulder. You bring up your shoulder, trying to have it make it tense for a few seconds, hold it there, and then you release it. That tension to the muscle for a few seconds and then releasing it brings some neurotransmitter to help relaxing that muscles. And you continue down with the arms, and then you go down toward the waist, pelvic, and legs, and go down. This is something actually initially was developed during martial art as well too. So after intensive workout, so what they did do, they tense the muscle individually and then they slowly relax it. And after a while, when you start focusing in your mind in different area of the body, after a few seconds, and you go through the body all the way, so basically you start relax the entire muscle of your body. This pretty much not to the extent of the sedation medications, but it's one of the very effective relaxing method that you could use to just relax the muscle. Other way to think about it, you're going to, for example, a sauna or a jacuzzi, and you have your muscle tense, and after a while, it gets relaxed. Behavioral therapy is by far one of the most effective one for the insomnias. That's more of precipitating factor that, for example, there's something going on in life, there's anxiety, we get diagnosed with a new illness, or a family going through something, you have a life challenges, and you need to cope with it. You have some sort of underlying anxiety that you can't figure out what is it coming from. Sometimes there's a reason for it, sometimes there's no reason for it, and we have to figure out. At the end of the day, any symptoms that we experience, the best way to treat is to figure out what causing is. When you find what caused that symptom, then you look at it and you treat it as a target pointed treatment, rather than just give them medication, let's do this, let's have tea. But what if this thought or anxiety is related to something that make us worry and we can't sleep? Because every night we go to sleep, we think about this happened to our dear loved one, or what I'm gonna do for the rent for the next couple months. And when we don't know, it's gonna be difficult to acknowledge that anxiety or underlying cause of insomnia. So that will make it harder to treat. So when we do the behavioral therapy, usually by psychologists or therapists, that's nothing that happens within the 1-2 sessions. It pretty much you need about minimum of 4 to 8 sessions to figure out what's going on in our mind. And we get to the point to acknowledge that, for example, anxiety or mental occupation that we have. What they try to do is to help us acknowledge that issue, anxiety, or the problem that we have. We tend to understand it. We kind of step back and we observe that. So acknowledging it is one step. And then the next step for that will be not let us being taken away by that anxiety or by that issue, but as we acknowledging it, we're looking from outside, and then we can divide it to a different column and different underlying cause to see if there is something we can do about it or we cannot do about it, and what are the things we can do about it so we can start working toward it. So think about it, what will be the catastrophic thought behind it, and then we try to deal with it. So the idea basically of this one is that something causing us that anxiety or inflammation because our body is not coming down anymore, we're not getting relaxed to sleep, to figure out what is it causing it as a third person, to be not in our body but kind of away and see what's going on, to acknowledge it and then analyze it. The MBSR techniques are mindful-based stress reduction techniques. Basically has a similar concept with the behavioral therapy. It's more acknowledgement. There are multiple different techniques. That's a very broad techniques. If you were ever familiar with the MBSR techniques, to figure out, to help yourself or help yourself to be more mindful of what's going on in our body, what's going on, what is it? You have a feeling, oh, I think something is bugging me, but I don't know what it is. Or I have a feeling of an urge to do something I don't know. Or you know what you want to do, or you have what urge you have, but you don't know the reason behind it. So the MBSR techniques helps us to pretty much step back from ourselves and look at what's going on, and that would give us a better analysis. And hence, when we know what's going on, so we can treat it better or approach it better. So the other part of the behavioral therapy, basically going to think about what's going to be the worst thing happen. For example, what's the worst thing happen? For some people, if I die, would be the worst thing happen. For some people, I mean, I would probably die, but what if my family, if I die, what's going to happen to my family? So what's the major cause that makes us worry? And then what's a realistic expectation? What are things we can do about it? What are things we can be positive about it or no? And then also re-educate and reinforce of the sleep hygiene is also part of the behavioral therapy too. So by this statistic, many of you may say, oh, I've been to the therapist, it really didn't work. And that's true. Sometimes you try therapies and it's just not a good fit for you, but that should not be discouraging. One of the trial, for example, for medications or different approach, or even pain medication or antidepressant medications, is a trial and error. There is one person that therapy is actually going to be a good fit for you, and then you click and you feel that person understands you better. And then from there, you start following and things make sense. Sometimes your therapist has shared a similar experience as you did or has a better understanding. Sometimes female gender or male gender would be make a difference. Sometimes the type of education background or culture would be different. So the point is, one session, two session therapy is not working. Probably we should give it some time, either with same therapist or even change the therapist to see who will be a better fit for us to go. So, and basically reiterating the same thing that we talked earlier about the quality as we get to sleep more. Now, going some other approaches. So that was initially the mindfulness, understanding the underlying cause of the sleep problem or insomnia, and figure out what is it coming from, what's the root, and do some sleep hygiene. The next step would be, what are some of the things we can do? Any questions so far? All right, so now we get to the point that we're going to use some additional aid to help us sleep. One thing I'd like to mention is usually when we dealing with some sort of symptom or underlying cause is when we approach with one method might be just enough. Okay, we talk about this anxiety, for example, at night, and we have this issue, we talk about it much better and go, but it's usually not the case. One thing we'll learn in medicine is it's good to have multi-approach. So we use different mechanism action from different angles that will help us to get through that problem much easier, much faster. So other thing is start doing something in addition. So remedies or medication. I listed some of the remedies up there: valerian root, chamomile, passion flower, lavender, mint, etc. There are many things, homeopathy or natural remedies available over the counters. I don't personally have much experience with those myself. I know some people, they really love taking, for example, green tea, although green tea also has caffeine in it. So they're decaffeinated green tea is also available, but they feel calm with it. So these are part of those trial and error to see what works for you the best. When I Googled it myself, the valerian root apparently is over the counter and is readily available. It seems to be the most known that help many people to rest and help them relax. So what these do naturally, the mechanism of action is pretty much similar to some of those medications that we use in a hospital setting or in the medicine or in outpatient setting for anxiety. For example, if you heard about some benzo group classes, for example, like a benzodiazepam, Ativan, Xanax, or things like that, they actually work on what we call the CNS, central nervous system, and calm down the firing of the neuron, that hence it will help you to feel relaxed, hence helps your muscle relax. Some of the underlying mechanism action of the component of those remedies mimic the similar mechanism action of those medications, which more target based. Other over-the-counter sleeping aid, one's well known is the melatonin. So what melatonin is perfectly is a natural hormone sleep that our body produces at nighttime and basically stop producing in the morning. So that's when we have the jet lag or we have a different time of work hour, or we fly to a different country with different timing. That's what it gets messed up, for example, because the hormone is still on the same schedule producing to put us into sleep. And then we just wide awake at nighttime and then asleep in the daytime. So melatonin is the actual natural hormone the body produces, and by far is one of the most safest medication to use and available over the counter. It's sometimes you can use it as what we call a PRN or as needed. For example, I'm not falling asleep. Let's take the melatonin, 3 milligram, 5 milligram. I think 5 milligram and 6 milligram are the ones available over the counter. Although the best thing is to get to that sleep hygiene with a routine sleeping time. The best would be to have a routine melatonin. Take it the same time at night, 7 p.m., 8 p.m. About an hour before you fall asleep, so it can kick in and help you and continue consistently with that melatonin for a while until you feel you don't need it, and then get out of it, basically. So this is that hormone that Dr. Gill was talking about, that early adulthood, when we're child, how we can fall asleep very easy if we don't sleep, and as a teenager, we don't really need much of the recovery, versus when we get to the middle age or older, we tend to sleep earlier, wake up earlier, and then if we resist sleeping, for example, for a day or two, the recovery from that is not as easy, is just because of the amount of the melatonin is being released in different time of our age and the timing of release. So for a younger adult, it's going to be later. For a middle age and older, start releasing earlier. That's how we have a difference between adulthood or late adulthood versus earlier, as far as the timing of sleep. The other over-counter medication, Benadryl, other name is diphenhydramine. Most of us familiar with the antihistamine mechanism. So basically, we use them for mainly for allergy reactions, allergy difficulty, for example, nasal allergy. Some people take it for nausea, motion sickness, for the airplane or the boat. And then because of sedation effect, some people use it for a sleep aid. So it does help feeling of sleepiness, but does not sometimes can help with the mind or muscle relaxing. So it's a hit and miss. It would help some people don't. So may worth a try. However, it's not one of those priority that we recommend to do right away. And this is more of the take it as needed sometimes, versus melatonin, we can think about it as more routine every night. And then the next would be the prescription medication by the physician. So if we as individual tried our sleep hygiene, we try to figure out what's going on with our body, we talk to the therapist, and we kind of analyzed the root of the cause of our insomnia or difficulty sleeping. And as we working toward making it better with the sleep hygiene and still not getting anything out of it, then maybe a medication is the time to talk to the physician and figure out what medication works the best for us.
Dr. Bat, Betsy has a question.
Please.
Oh, thank you so much, and thank you for doing this webinar. I have a couple of questions. I missed you. I think you mentioned the optimum time for exercising, but I didn't hear what you said.
Oh, sure. I actually do have another slide I'm going to show you in a second. So this is a circadian rhythm. Are you able to see this slide right now?
Yeah, and I had some questions about circadian rhythm too. So why don't I go ahead and ask that? Are you familiar with like apps like Time Shifter that help people program circadian rhythms when traveling or just living life?
Oh, it's an excellent question. I don't know any specific guideline or suggestion per se for that one, but individually will be different. So the best is to slowly change the hours by 1 to 2 hours of the change. For example, now if I'm going to Australia, which is completely opposite, and then everyone's going to be falling asleep at 9 p.m. or 10 p.m. and I'm like wide awake until like 3. So and then my workout exercise here was 7 p.m. When I go there, it will be completely different. So the best thing is to readjust within few days. So change and pull every activity by 1 to 2 hours every night. Changing, it's okay to fall asleep a little bit later. Now, instead of waking up at 11 a.m., try to wake up at 10 a.m., put a clock, 10 a.m. or 9 a.m. And then the night, when you get to the night, try to go sleep in earlier too. So every activity, as you see in this schedule, we can pull it or change it about 1 to 2 hours every day. Within a week or maybe less than a week, we should be able to change it. Medication-wise, melatonin would be the helpful. So as we going to sleep, if we're not falling asleep, we want to try melatonin. If normally we can't do rescheduling, the melatonin will be something we can help get through this one. So this is the slide you mentioned about the exercise time, which is about like at 5 p.m. I'm not sure if Dr. Gill has anything to add.
Yeah, the apps that you asked for, I was just looking right now if I could see, but I think if you have an iPhone or the Google phone on the Play Store, if you type in circadian rhythm, you should be able to find apps that can help kind of track your, I think, your sleep cycle. And if you have a smartwatch, that can usually do it too. But what I do when I go on trips is I try to adjust to the time I start doing it before I leave. So if I know, like, if it's going to be the opposite, then I try to adjust by like Dr. Bat is saying, a few hours, which is like, difficult to do if you're still working here, right? So I try to adjust before and also kind of on the plane, and then use kind of melatonin to help me sleep earlier when I need to. So when I get there, I'm already kind of on the schedule.
Okay, that's helpful. Yeah, I saw the Time Shifter app, and in traveling, they recommend what you're saying, like kind of sleeping at different times or waking at different, so that when you land, you're in sync with the time of day it is wherever you're going. So, and this chart is very helpful. I guess my last question was about aromatherapy. Is that I've seen recently some aromatherapy mixtures that are market themselves as being especially for sleep or calmness, sleep mostly, and I was wondering if you have any thoughts on those as well.
I think those are great pointers, and I think I think would be a little bit more of the individualized. The aromatherapy is something that more studies coming up right now. Is still under study. Some people getting a better result than others. Some people more toward, like, for example, music, relaxing music. Some people more exercise. So I think it worth trying every different one to see what works the best for us, and then just like an app. And then what works the best, because at the end of the day, I think the best physician is ourselves. Like, you are your best physician at the beginning because you know your body the best, and you can help the physician to figure out how to basically navigate you. So for aromatherapy, I think definitely worth the trying. Dr. Gill, do you have any other?
Yeah, no, I think like you said, it's person to person. Some patients, some people it may work, some people it may not work. But you can always try it and see if it's helpful. And I think it may also be like the lavender smell, or that can also kind of help kind of calm the body. Essentially, that's what you're doing, calming and relaxing, which is going to help promote sleep.
Hopefully that was helpful.
That was extremely helpful.
Thank you.
Both.
Yeah. All right, so going back to this slide, we have a few more slides to go, and then for the sake of the time, I might go a little bit faster. We talked about a little bit of the cancer as well. There is again, so different technique as you mentioned as for the aromatherapy. So there is acupuncture dash acupressure points. Also same mechanism action for more of the anti-nausea and anti-vomiting. These are the points that, as you see in the slide, for like different numbers, P5, P7, P9, that acupuncture use to put a needle for modulate the neurons, the way they fire, for either reducing the pain or modulating the neurotransmitters in a way that the muscle at the area or the nerve at that area kind of calm down. So one of the suggestion is to do this acupressure. It's called Neiguan. Neiguan by dictation would be internal gate. So this point, which as you see in the photo, with 3 finger right below the wrist, in the middle of the forearm, that would be a 0.6. If you can see, I don't know if you see my mouse, but it's going to be right here. If you put some pressure, and you have to wait for a good seconds, like 20 seconds, 30 seconds, put a pressure on it to have that pain reduction or nausea reduction. and for some reason try to look the mechanism of action if it's pressing on a specific nerve or no, but it's still didn't find a solid answer for that, but it does help with relaxing entirely. That may help the insomnia too. Something to try again. Coming back to the cancer patients, things going to be a little bit different. As you remember, if Dr. Gill was initially explaining about different causes, so this is a more complex issue. There is an illness part of the insomnia, and there is anxiety part of the insomnia. There is mind being occupied, so it's kind of a mixture of all above. So that's why we need to address multiple different ways to help with this insomnia too. Very easily, people who get diagnosed with cancer, the beginning may feel anxiety. What's going to be the next level, what's going to be the end. And then as the anxiety grows or continues, it may cause with depression too. So just having depression, anxiety by itself, it can definitely cause some insomnia, change rhythm. Even like the patient could be calm, resting in bed at night, in middle of night, maybe just jump and feel this burst of anxiety. Or the other way around, it gets too depressed, too hypoactive, and try to have very sleepy daytime, has no motivation to move, so you sleep a lot more in the daytime, and that will cause not much sleeping at nighttime. The other thing that during the medical treatment, the medication that we use, as Dr. Gill mentioned earlier too, for example, a steroid, which has a multiple different action during the cancer therapy, depending on what type of therapy we use, can cause also racing a thought and agitation or feeling pressure for someone who's trying to sleep. One way to do it is to have the steroid list as far as the dosage, or give it in the afternoon early, maximum by 2 p.m. Other things, someone who's having cancer-related pain or different procedure pain, and we're giving pain medication. The pain medication tend to be sedating and sleeping, so our loved one or a patient can sleep more again in daytime, so it will kind of cause difficulty at nighttime. Same thing with nausea. So someone has chemotherapy, and for the next 2 to 3 days after chemotherapy, experiencing some nausea in the middle of night. So all this brings a sleep interruption. Speaking of a sleep interruption, being in a hospital, you may get up in the middle of night. Hey, I need to do a blood test. Hey, you have more medications to give. So, or next door is beeping, or the roommate's not falling asleep. There's other noise from the other part of the hospital can cause interruption to the sleep. So this is again exploring how a cancer patient going through the chemotherapy or the cancer treatment can experience some insomnia. The other thing would be actual pain. So the tumor or cancer can cause pain. The surgery can cause pain. For example, a patient can have a surgery. After the surgery feels okay, but then at nighttime everyone's sleeping, and then the body feels inflamed, body feels in pain. The area of the surgery causes problem. Sometimes there are devices attached, there are tubes attached to the body, tubes for the kidney or tubes for the abdomen. Every movement can cause difficulty sleeping. Sometimes some chemotherapy causes something we call neuropathy. It's actually inflammation of the nerve from the chemotherapy. So the patient may experience pain in hands or feet, sometimes lesions in the mouth or skin. So, or simply just the hospital bed is not the one that we got used to sleep comfortably. And then there are the other complication of the treatment. So we give pain medication, and when we can have constipation, so we get abdominal pain, or the infection we get or the type of medication we get, we have reaction to it, can cause fever or chills or nausea. So all these symptoms can contribute to the disrupting the pattern of sleep. How to approach it? So once again, going back to see what's the underlying cause, it will help us the best for a targeted therapy. However, in the cancer patient, it will be different things that can cause. So one thing as far as the anxiety goes, the best We can do a therapy that could be a group therapy, could be a psychotherapy one by one for every patient. That majority of the hospital do provide that. Again, cognitive behavioral therapy and MBSR techniques. So these we already talked about. So it's a combination of all above. As far as medication goes, we can change the medication, see if there are too many medication that we have to wake the patient up. One of our job as a palliative care physicians, Dr. Gil and I, is to figure out the medication can be less numbers. Can we change them, adjust the dose for the sedation? Are these too strong for the daytime to sleep too much? Maybe we should go back. Or how about we can adjust the time instead of waking up at 4 a.m. and then 11 a.m. and 6 p.m. Can we do it, for example, 6 a.m. and 12 or 1 p.m. and then like 7 p.m. so we don't need to wake the patient up in the middle of night. And same thing with the steroid. The latest to be given, keep it as 2 p.m. so we have enough time for the body to calm down. This is again, so as talked to Betty earlier for circadian rhythm, just a quick overview of how this is again from the study, how our body works as far as for example, you think about on top midnight, at 2 a.m. would be the deepest sleep, 4:30 a.m. the lowest body temperature, the sharp blood pressure would arouse somewhere a little bit before at 7 a.m. and then that's melatonin stops at 7:30 a.m. or so. Then you have the highest alertness around the 10 a.m. So I'm not sure if anyone else experienced that. Sometimes we take tests, for example, the best time for taking a test is in the morning around 10 a.m. Sometimes maybe for some people it would be afternoon. As so forth going up, I think that 1700, which is a 5 p.m., that's the best time for any cardiovascular workout. Now, that being said, some people are morning person. They love working out cardio in the morning, but most people get a better result in the afternoon. And goes on to back to the 7 p.m. and then 9 p.m., which the melatonin start secreting again. That being said, I'm sorry for the last few slides. I went a little bit fast. I just want to make sure that we have a few minutes before the end of this lecture, so we have more few minutes if anyone else has more questions for us.
We do have one question in the chat box. She asked, do you build up a tolerance to melatonin?
I haven't seen here a big tolerance. There were incidents that the people needed more. For example, from 3 milligram went to the 6 milligram, but I didn't, or for example, 9 milligram. I haven't personally seen someone to need it to go that much high to feel dependent on it. Usually the amount should be good enough to give us a good enough amount to fall asleep. And if it's not enough by that dose, we do additional medication or other medication. So instead of going up on the melatonin, we do adjunct with different medications, because by the time it's already we at the therapeutic level of the normal hormone that we have. And then as we add other medications or relaxation method, or that life crisis passes on, then we cut back on the medication and cut back on the melatonin, then going back down. So I haven't seen myself a big tolerance, and I don't really see that we go up on the melatonin in a high dose. Usually after a certain point, we just add additional medication. So we keep the melatonin to the same amount. I don't know if Dr. Gil has anything else to add.
Yeah, just to kind of add to that, there's no like studies don't show any evidence that you develop tolerance to it. And Dr. Bad said, usually that low doses work pretty effectively, like if they're going to work, and just increasing that is not going to be very effective. And then we need to think of like maybe other medications. And still, while we do this, still very important to continue with like sleep hygiene, along with other medications if we try them.
That was an excellent question, though.
Another question is what time to take melatonin? What is the best time?
So There is, usually it's recommended like maybe 30 minutes prior to bedtime. Some say take it kind of like after dinner, like more evening time. So I've had patients say that, you know, it works like better, like 30 minutes prior. So you do need some time, you know, before you go to bed to take it. But if you take it and then expect to sleep right away, you know, that may not happen. So I would say kind of also trial and error, see what works for you and how your body reacts to it.
Yeah, exactly. So 30 minutes to 1 hour is a suggested time to take the melatonin. But also something else to add is if we're planning to do something else, for example, oh, I'm going to take a melatonin, but then 20 minutes after I get distracted to do something else. Oh, I remember about this email, so I have to do this email and I start doing this email, which take me another half an hour to read or respond to this thing. So it kind of pushing and resisting against that melatonin affecting, it also kind of going to disrupt it as well too, because the other part of body is like a seesaw. So we trying to have the body with the hormone to come down to sleep, and then we just created additional exciting factor by, you know, let me watch this another episode of this show, or let me, you know, how about let me make this call or make this email, and we push another hour. So by that time, we kind of destroying, we adding an additional hormone to excite that melatonin away. So that would not be a suggested thing to. Same thing go with different medication for sleeping. If we trying to take medication, melatonin or any other medication that's been prescribed by a physician, it's better to take it half an hour to 1 hour before, but it's when we commit to a sleep, we have to commit to a sleep.
And then a follow-up question, is it safe to take melatonin if you're on a sleep aid?
Usually is, but depending on the pattern, depending on the cause of sleep issues that we have to figure out, and that the other medication, my suggestion would be definitely talk to your primary doctor, because, or the doctor who prescribes that sleeping aid medication, to make sure. I'll give you an example. For example, if someone has a COPD or using BiPAP or CPAP at night, or some difficulty for breathing, so we don't want too much of the sedation, for example, so we have to be careful about those. So double effect of a sedation or a sleeping aid medication plus a melatonin, which usually is safe. I would not recommend that if you're doing it on your own. If you are on some medication, the suggestion would be run by the doctor to make sure it's compatible with your condition and with your cause of the insomnia. Dr. Gill, if you have any other.
Yeah, no, I think I agree. The only risk is, right, that you're gonna have more sleepiness because you're taking another medication to fall asleep. So there's always that risk. So you have to be careful, make sure that you talk to your primary care doctor about it before taking both.
But it does happen. We have people who you give melatonin and then we might give some additional medication to sleep as well too. But again, it goes back to the cause of the sleep problem and the medical condition. These are all good questions though. I'm happy with all these questions. They're very active. And
Another question is, do you have any recommendations for 3 a.m. wake ups?
It's gonna be the same thing with sleep hygiene, but I think the other key thing is figuring out why you're waking up at 3 a.m. Is it because you are like getting up to urinate a few times a night, or is it that you're thirsty, you're drinking water, and then you're urinating, right? So we have to first find out why you're waking up, and fix that underlying issue. But it would be, again, do the sleep hygiene, that if you feel like you're wide awake, then, you know, get out of bed, you know, especially if you're not falling back asleep within like 20-ish minutes. Get out of bed, try to do something that's not super stimulating for your brain. You know, no screens, nothing like that, but something boring that's gonna make you fall asleep, and then go back into bed.
Does anybody else have any more questions? No? Well, I just want to remind everybody that they will be back on the 28th talking about chemotherapy. And thank you, Doc. Oh, somebody does have another question. Have you heard of melatonin waking people up?